This video shows you how to do pre-procedure CT planning using the Redo TAV app. For index TAV is Sapiens 3 and second TAV is Evolut, Allegra, or Navitor. When you click Redo TAV CT planning on the home screen, first you will get the overview of all steps you need to do. The CT acquisition protocol can be the same with routine pre-TAV assessment. It's recommended to obtain ECG-gated multi-basic functional CT that covers the entire cardiac cycle with ideally 20 phases, a minimum of 10 phases. The mid-diastolic phase generally has fewer artifacts, allowing for better assessment of the process reflex and commissure alignment in most patients. The end-systolic or end-diastolic phases could be used as alternatives. The first step is index TAV and measurement. If a pre-index TAV CT data is available, select native valve morphology and the severity of calcification, and identify your patient index TAV type and size. And then you will get the fundamental information of the valve. The leaflet of Sapiens 3 will extend to the top of the commissure tab when it's pinned out by a second tab. So the top of the commissure tab is the reference level for index Sapiens 3. On the next page, select the index tab failure mechanism and assess commissure alignment. Open your patient's CT dataset on a CT software. We can use any CT software. We just need 3D MPR multiplanar reconstruction module. After determining the appropriate cardiac phase, align the MPR to be orthogonal to the valve. And assess commissure alignment, which refers to the relations between the native aortic valve commissure and THV commissure tab. The commissure offset is directly measured using an angle tool with the limbs aligned with THV commissure and the native commissure of the RCC and LCC. This case has almost aligned commissures, so select aligned. And perform the measurement of area and perimeter. These measurements will be used for second tab sizing later. We can also understand how much the index TAV is underexpanded at this point. For Sapiens 3, 3 levels require your assessment: outflow, base, and inflow level. Here is the outflow level, making sure the MPR is precisely orthogonal to the valve, and measure the area by tracing the center of the stent frame because of less blooming artifact. And you will get area and perimeter. Next, move to the base level, narrowest level, and again measure the area by tracing the center of the stent frame. Adjust the tracing if needed. And lastly, move to the inflow level. Again, measure the area. After or during the measurement, please fill in the areas and the perimeter in the app. Step 2 is identify your patient coronary risk limb, which is defined as the lowest level of coronaries in relation to the Sapiens 3 reference level, where is the top of the commissure tab. On the CT, now we are in the inflow level, so scroll up the plane. Now we are reaching to the bottom of LCA. So align the MPR to the LCA to identify the relationship between the bottom of LCA and the top of the commission tab. So now the bottom of LCA is below the top of the S3 commission tab. Next is RCA. So scroll up again, and now we reach to the bottom of RCA. Adjust the MPR line and identify the relative relationship with the top of the commission tab. So the bottom of RCA is just below the top of the commission tab. In the app, select the bottom of RCA and LCA ostium, and the app automatically identifies the coronary risk plane. All commercially available toll valves could be selected as a second tab. No matter which toll valve is implanted, it will result in complete pinning out of the Sapiens leaflets. So minimum height of the nail skirt will be at the top of the commission tab. Positioning the inner skirt of the second tab higher than this level will result in taller nail skirt, increasing the coronary risk. Therefore, it's important to ensure that the inner skirt does not exceed the top of the commission tab, except for accurate valve. Accurate has a unique structure of upper ground, so I separate the video only for accurate in Sapien or MyVal combination. This is for Navitor, Allegra, or Evolut in Sapien 3 or MyVal combinations. When Navitor is selected, inflow-to-inflow implantation is recommended to secure the anchoring and gain appropriate expansion and hemodynamics. For Allegra and Evolut, implant depth should cover the nadir of Sapiens 3 leaflets, and node 3 of Allegra or Evolut should be close to the top of the commission tab to gain good anchoring and optimal hemodynamics and expansion. From here, the process is the same for Navitor, Allegra, and Evolut. So I'm going to use Evolut as an example. For these combinations, there is only single selection for the nail skirt plane. This level, top of the commission tab, is above the coronary risk plane in this case. So further coronary assessment is needed. Step 5 is in vivo CT sizing. We already measured the areas and the perimeter at step 1. In the app, these 3 levels are pre-selected for convenience. Please verify that the measurements are correct, and if you'd like to, check the button of Include Perimeter and click the Calculate button. Then you will get calculated average area perimeter as well as area derived diameter, perimeter derived diameter. Due to FDA regulations, the app is unable to directly suggest sizing. So you will need to choose the second tab size based on your CT measurement. Here has some guide how to choose size. And here you can get the IFU table too. For this case, I will choose size 30 for Evolut. It is generally less probable that an index tab will be expanded by a self-expandable second tab without performing either pre or post-rotation. The VTA distance should be measured from the stent frame of the index tab. Then, identify the narrowest VTA distance within the zone from the nail skirt plane to the coronaries. This evaluation is particularly critical when the nail skirt plane is above the ST junction. This is stating a careful assessment of the VT-SUJ. The app is designed to automatically determine the relationship between the nail skirt plane and each coronary artery. When the nose cut plane is above either the RCA or LCA, it's important to further evaluate the relationship between the nose cut plane and the ST junction. We recommend to assess RCA and the LCA separately. So let's start with RCA. So now here we are at the nose cut plane, top of the commissural tab. So first assess the relationship with the ST junction, which is below the ST junction. So first visualize the VT, aortic sinus, from the index stent frame, and then a little bit scrolling down, and now at the VTC. And then fill in the app. Next is LCA assessment. So first, bring the plane back to the nose cut plane. And assess the relationship with the ST junction. Now for LCA side, which it is just at the ST junction. So we need to measure the BTSTJ from the stent frame, which is 3.3 millimeter, and scrolling down, measure the BT aortic sinus, BTAOS, and then scrolling down further, at the middle of the coronary ostium, measure the BTC, and fill in the numbers in the app. Then you will get summary reports of 3 pages, which include animation representing the relationship between the nose cut plane and both coronaries. You can take screenshots and also import these reports into CT software summary report, like 3 mentioned. If available, the information of a pre-index TAV CT can be gathered at step 8. This information can help you planning more precisely. Let's see the case of nose cut plane below the coronary risk plane. So here is a CT image of the case. The nose cut plane is below the coronary risk plane. So now we are at the nose cut plane. Now we can see the bottom of RCA, which is above the nose cut plane. And now you can see the LCA, which is also above the nose cut plane. And in the app, you can select the bottom of RCA and LCA, and the app automatically identifies the coronary risk plane. Step 3, select the second tab and assess the relationship between the nose cut plane and the coronary risk plane. In this case, the nose cut plane is below the coronary risk plane, so risk to coronary is considered as low. Do the same steps for sizing. I will choose size 34 based on my CT measurements and the IFU table. Then, as I mentioned, in this case, the nose cut plane is below the coronary risk plane, so no need further coronary risk assessment by measuring the PTA distance. Then you will get the summary report of 3 pages, similar with before. And also the step 8 pre-index TAV CT dataset. This is all steps you need for pre-Redo TAV procedure planning. I hope this video helps your planning. Thank you.